Assalamu alaikum wa rahmatullahi wa barakatuh. Today, inshallah, we will talk about trauma assessment in ER. This lecture or this session will be an interactive session. I will present multiple cases, and I would like you to participate in these cases so we can have, inshallah, a good outcome together, inshallah. Let's start in what we expect from this lecture, inshallah. What our objectives is to apply the ABCDE approach in trauma assessment and identify the life and manage life-threatening emergencies or conditions early. We also aim to recognize common pitfalls and avoid errors. And lastly, we will address some special trauma population like pregnancy, geriatrics, and pediatrics as well. Why systemic approach is very important in trauma? Because of three things. And the first thing is that trauma is a leading cause of preventable deaths, and early intervention and management can save lives. And in these cases, we need teamwork and communication to have a good outcome and save lives as well. Without further ado, let's start with the first case. A 32-year-old male is brought to the emergency department by EMS after a high-speed motor vehicle collision. He was found unresponsive at the scene. There was significant vehicle damage, and he was extricated by the fire department. No known past medical history is available. EMS reports a weak pulse and labored breathing. No obvious external bleeding is noted. Kindly in the chat section, answer this question. What is your first step? Get a CT scan first, apply a C-collar and assess airway, start IV fluids immediately, call neurosurgery first. What do you think? What is our chat box? Yes.
He will choose B.
Dr. Arafa. Dr. Adnan, mashallah. Okay. So, according to the ABCD approach, we will choose number B, are correct. Okay, and we will start by assessing the airway. When we assess the airway, we found gargling sounds and no verbal response. Dr. Adnan, since you're the one who spoke, can we please discuss these two questions? What is your immediate priority for airway management, and how would you confirm adequate airway patency, please?
Hello. First of all, as early assessment, first assessment, I will assess the type of breathing. If there is,
yes,
the patient is normal as synchrosis, as normal breathing, or labor breathing, or any difficulty of breathing. We'll assess the airway from nasal to from nasal oral. If they are, there is no any airway obstruction. We'll try to monopolize straight on line, and we'll make the jaw rest a little bit by straight on line to open the airway if there is any difficulty breathing.
Okay.
Can maintain by airway, put airway to open at least straight the airway to maintain the oxygenation for him.
Okay, so this patient have gargling sounds and no verbal response. What is your immediate priority for airway management?
According to the GCS, now the patient needs rapid sequence induction for intubation. We will prepare for intubation, but if there is any according to this, will intubate this patient and will call for help. If there is a call for second hand, for us to do straight online intubation.
Okay. How would you confirm an adequate airway patency, please?
Adequate, first of all, by auscultation and by pulse oximeter oxygenation. By auscultation, the airway, by auscultation and by pulse oximeter. This is the early can to check the adequate ventilation.
Okay. Thank you, Dr. Adnan. Thank you very much. Okay, as Dr. Adnan said, this patient have gurgling sounds and no verbal response, our immediate priority for airway management is to open this airway and maintain it open. And how would we confirm that we have adequate airway patency? By putting a definitive airway. And what do we mean by definitive airway? We put a tube basically or something in to keep the airway open either from his mouth or from his nose, but the most common site is we do from the mouth to the trachea of the patient. We should have like an open and patent maintained airway. Okay, this is regarding the airway. Let's move to the next item, which is breathing. Our patient has labored, shallow, and asymmetric breathing and asymmetric chest rise. Can someone volunteer and ask and answer these two questions? What do asymmetric chest rise and labored breathing suggest? And what immediate interventions are needed?
As doctor, as labor breathing, that means some upper airway obstruction. There is degree of upper airway obstruction because the patient breathing against something obstructed.
Yes.
Or something compressed.
Okay. Thank you, Dr. Adnan, for your contribution. Can someone else contribute or try to answer, please? Or should I pick randomly? Can I ask Dr. Ragi?
Sorry, what was the question again? I just joined now.
Okay, welcome to the lecture. We have a patient, a 32-year-old patient, was involved in a motor vehicle accident, and his airway, he had gurgling sounds and no verbal response. And when we assessed his breathing, he has labored shallow breathing with asymmetric chest rise. These are the two questions in this time. What do asymmetric chest rise and labored breathing suggest?
For that, maybe there is an airway obstruction with maybe foreign body. Also, we can consider a pneumothorax if there is asymmetric rise of the chest.
Yes, good. Yeah.
Flail chest also we can consider.
Good.
And for the immediate intervention, we will follow the ACLS guidelines. First, airway protection.
Okay, we've managed that already. We're now in the step of breathing.
In breathing,
yes.
Now we will auscultate the chest. If there is a decreased air entry on one side, indicating there is a pneumothorax, we will catch.
Okay. Okay. Good.
Okay, then we will assess the breathing also by using a mechanical ventilation or until we confirm the insertion of the chest tube by other follow-up chest X-ray.
Okay. Good. Thank you very much. So asymmetric chest rise and labor breathing suggest multiple things. Tension pneumothorax or simple pneumothorax, or any fluid or hemorrhage inside the chest, hemothorax or pulmonary contusion. And depending on my differentials, when I listen to the chest and assess the chest rise, if I have significant decrease of air entry, for example, on the left side, then this might push me towards the pneumothorax. And what I need, or what the intervention that I need at this time, would be like a needle decompression or finger thoracostomy before I put a chest tube. In trauma, we need to have two things, or two kinds of assessment. Okay, like an immediate primary survey and immediate primary intervention, and then we will have a secondary survey and secondary intervention. During primary survey, we survey for what kills first must be treated first. So we started with the airway. We had a gurgling sound and no verbal response. So Dr. Adnan opted for an endotracheal intubation to secure the airway and keep it patent. In the second step, which is breathing, we have a shallow and rapid breathing with asymmetric chest rise, and Dr. Raghi suspected pneumothorax, and he opted for a chest tube. Okay, we will discuss this a little bit later, but for now, in primary survey, we don't put the chest tube, we just open the pneumothorax or transverse it from intention pneumothorax, which is life-threatening and would kill the patient, to an open pneumothorax, which is a less severe condition that will give us time so we can intervene and manage the patient. Okay, thank you, Dr. Raghi. Now we finished the first two steps, which are airway and breathing. Let's move to the third step, which is circulation. We have a blood pressure of 80/50, a heart rate of 130, and the patient looks pale with cool extremities. Again, two questions. What are the likely causes of hypertension in such patients? And what is the most appropriate initial fluid resuscitation? MashaAllah, we have a lot of candidates. Again, we have this patient's blood pressure is 80/50, heart rate of 130, with pale and cool extremities. What are the likely causes? And what is the most appropriate initial fluid resuscitation? Can someone volunteer and answer, please?
In this patient, the trauma patient,
Dr.
we're
Arafat.
suspecting so hypertension in a trauma patient, we're suspecting bleeding. As a rule, in the trauma patient, we search for the site of the bleeding, for one on the floor and four more. One on the
Good.
floor may be external bleeding from any side.
Good.
Four more may be hemothorax, hemoperitoneum, and the fracture pelvis and fracture long bones. We should exclude one by one.
Okay.
The first the most appropriate initial fluids may be ringer lactate.
Ringer lactate. Okay. Good. How much? What's the volume that you're looking for?
1 liter.
1 liter.
1
Good.
liter. Then start blood transfusion.
Good. Thank you, Dr. Arafat. MashaAllah. This is a very good answer. In any trauma patient, when we see a hypotension, as Dr. Arafat said, we suspect 5 places of bleeding. External bleeding that is obvious, or we can see it on the floor, blood on the floor, and 4 more. The 4 more are 4 more sites inside the body, which are the chest, the abdomen, the pelvis, and the long bones. Okay, and the appropriate fluids are usually the linear lactate, 1 liter of normal saline or linear lactate maximum, and then we start blood transfusion. It's better if the blood is available to start the blood early, especially if we suspect bleeding, and move the patient according to what we find in his injuries to OR or something. Thank you, Dr. Araf. The fourth step in assessment is disability. We found that this patient's GCS is 6, 1 for eye, 1 for voice, and 4 for motors. What does a GCS of 6 indicate, and what imaging should we prioritize? What do you think? Dr. Hisham. Dr. Hisham. Or Dr. Hamza. Can you hear me?
GCS under 8 indicate intubation.
Okay. Indicates, what does it indicate?
Indicate patient can take his breath unconscious and need immediate intubation.
Okay, we've managed in the airway step, we've already put an endotracheal tube. We've done the intubation step in the airway.
Yes.
If I said to you, Dr. Karim, this is a patient, a trauma patient, and his GCS is 6, what would you suspect?
Is patient unconscious and the brain perfusion is low.
Okay.
According to circulation hemorrhagic shock, or according to lower amount of oxygen arriving to the brain. So as we told before, we should protect the airway first.
Yeah.
And also correct the pneumothorax, if there is pneumothorax,
Yeah.
and proceed to correct the shock.
Okay.
Like
Okay.
this ABCD.
Okay. Good. Good. Anyone else? Okay. In such patient, we would suspect one of two things. Yes, please.
Yes, we suspect, of course, a traumatic brain injury.
Okay. Good.
Because it's low GCS.
Good. Good. Very good.
Yeah. And in that case, also, we would consider that there is a cervical injury, so we have to protect also the cervical spine.
Okay.
Because this indicate, according to this Glasgow, it's a severe traumatic brain injury.
Okay. Good. Good. What imaging should we prioritize in this patient?
CT brain and it is cervical spine also.
Okay. Okay. That's good. So what does a GCS of 6 indicate? If we have a low GCS, we have one of two things. Either this is a systemic issue or systemic problem that causes hypoperfusion to the brain, and that's why this patient is GCS is low. And the other thing is there is a problem with the brain itself. Okay, in such trauma, in which we have a problem in the airway and a problem in the breathing and another problem in the circulation. Okay, this is a major trauma. So it's highly likely that there will be a problem with the brain as well. And we should prioritize brain imaging in such cases. Okay, we will address the cervical spine issue, or we should address cervical spine issue with the management or during the management of the airway, not delay it until we assess the disability or the fourth step of the patient. So again, to summarize what we have so far, we have a 33-year-old patient involved in a car accident, in a very bad car accident, and we've now examined and managed 4 aspects of the ABCDE approach: the airway, breathing, and circulation, and disability. The last part, or the last step, is we would expose the patient and examine his trunk and his extremities. When we exposed the patient, we found that he has bruising on the chest and abdomen and deformed left femur. Okay. What are our next steps after exposing the patient, and would we perform a log roll now, or why not? We need someone from surgery now to answer these questions. Where is the surgical team? Yes.
log roll في primary survey, but we should proceed the steps first, يعني the life saving as we done before, for the airway first, then the chest bracing, then the circulation, and we will proceed like the exposure, يعني the last one.
Okay, we've done all of that, and we are now in the exposure step, and we exposed the patient and we found that he has bruising on the chest and abdomen and deformed left femur. What would you do for this patient?
As we told, log roll last stabilization of the like slamming of the femur. Then after this we ask for help for the log roll, for person for the log roll.
Okay. So you would correct the deformed left femur initially by slapping it, and you would log roll the patient now, right?
Yes.
Okay. Why would you do it now?
Because if we may start log roll when we increase the deformity lesion and like arteries injuries, major vessel injury, or ischemia, like this.
Okay.
Or bleeding, decrease the bleeding. As you know, the fracture femur may increase bleeding up to 2 liters.
Yes. Good.
Hematoma like this.
Okay. Good. Thank you, Dr. Karim. Okay. So for such patient, when we have bruising on the chest and abdomen, this would raise a question mark for either lung contusion or chest issues, which we addressed in the breathing and airway steps. And and abdomen, if there is a bruise on the abdomen, this means we need to look if there is any internal organ damage. Like Dr. Karim said, either we suspect an internal organ or vessel damage, and we should correct the deformed left femur to minimize the bleeding as much as we can. Okay, so would we perform a log roll now or later? It's a debatable issue, but according to textbooks, it should be performed during the secondary survey, not during the primary survey. Okay, so let's recap if we have a trauma patient, we should go through 5 steps: airway, breathing, circulation, disability, and exposure. In the step of airway, we add plus it the C-spine. We look for airway patency, not just patency, and maintenance. It should be patent and maintained. Plus the C-spine or the cervical spine should be fixed as well until we clear the spine, and if there is no injury within, we can release the C-spine. In the breathing step, we look for any abnormal chest rise, abnormal breath sounds, especially if there is pneumothorax that can kill the patient or not. In the circulation, we look for a shock. Why the patient is shocked, especially if the patient is shocked, why is he shocked, and what's causing the shock. If we can do a rapid hemorrhage control and give him some blood products that he might need. In the 4th step, in the disability, we assess the GCS and the pupils and look for any brain injuries. And finally, in the exposure section, we expose the patient fully, front and back, okay, and look and be careful not to push the patient towards the hypothermia and decreased peripheral circulation. Okay, this is a summary for the primary survey in colors. So in airway, we look for, is it the airway patent, is it at risk or obstructed, and what is the condition of the cervical spine. In breathing, we look for the respiratory rate, chest expansion, work of breathing, the oxygen status of the patient. In circulation, we assess the pulse rate and volume, the perfusion of the in the peripheral limbs or the central, if the patient is he perfused centrally and peripherally or one of them, or no good perfusion at all. And we should have good large pore double IV access, one on the right side and one on the left side for good resuscitation. And then comes the 4th step, which is disability. We assess the consciousness, either using the AVPU score or GCS score. We check for blood glucose or tox screens and brain perfusion. On the exposure part, we use it as a segmental, or we do it segmentally, upper half, then lower half, then we check the back, and we care not to lower or push the patient towards the hypothermia part. Okay, what we can do in each of these steps. In the airway, we can do a head tilt and chin lift, given that we have no cervical problem, or we're not suspecting a cervical injury. But if we suspect a cervical injury, we just do jaw thrust. We can do some suctioning if there is some bleeding or secretions in the airway, and we can use any type of advanced airway with cervical collar and head blocks to fix or to immobilize the cervical spine. In the step of breathing, we can give the patient some oxygen and put him in pulse oximeter. We can ventilate the patient. We can do thoracostomy according to what he needs, and we can use. I think we now have the capnography attached to most of our monitors, so we can use the carbon dioxide levels or do blood gases to assess the breathing efficiency of the patient. The 3rd step, in the circulation, we can give the patient some fluids, maximum 1 liter of either normal saline or ringer lactate, and blood transfusion after that. If we suspect that there is an internal bleeding in the patient in abdomen, or we can use a technique called permissive hypotension, in which we keep the systolic blood pressure just above 90 millimeter mercury systolic to keep the patient perfused, but not to cause more bleeding until we manage the issue or the problem that's causing the shock or the bleeding of the patient. We might also use some vasopressors if we need, and we can do an ECG, but this is not a priority in the primary survey, it's in the secondary survey. Next, the fourth step is the disability. Okay, we can intervene to keep the cerebral perfusion by giving the patient, for example, good volume of fluids or blood products, and which can check the glucose level to maintain a good cerebral perfusion. If the patient ceases or start to have fits, then we have to control the fits, and we might use the sedation and analgesia to keep the patient calm and off pain, especially if we are going to manage his airway or put a definitive endotracheal tube. Lastly, in the exposure step, we do like primary deformity correction. If there is an obvious deformity, we do primary correction. It doesn't have to be definitive, it's just to support the limb or the deformed part of the body, and then we can manage it later. We can put some tubes, gastric tubes or any catheter. We can cover the patient to prevent hypothermia, and we can do the imaging as well. Okay, one very, 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 very important thing that we can do in trauma assessment is the ultrasound. As you may know, as most of you might know, the ultrasound now is in trauma called EFAST, E for extended fast assessment by sonography for trauma patient. This can help us identify the major issues in trauma patient. For example, in the lungs, we can identify pneumothorax. In the abdomen, we can identify if there is some sort of fluid collection or organ damage or can see that. This is very, very helpful and can guide our treatment. Okay? Any questions so far?
Dr. Omar, when we will use vasopressor in circulation?
Okay, we use vasopressors in circulation if we have used the fluids and the blood products and the blood pressure is still not raising and the patient is still shocked. Then we can use the vasopressors after that. But they are not a definitive treatment. The vasopressors are not a definitive treatment. They just like a bridge to support the patient until we can control the cause of the shock.
Neurogenic shock mainly also. This is I know, and this is a neurogenic. We are using the vasopressor. There is a peripheral vasodilatation for circulation, like there is warmness and like hotness in the peripherals like this, and we suspect of the lower limb like neurogenic shock. This is mandatory for vasopressor. And as you told, also we can use it if there is no response.
Yes, we can use it in neurogenic shock, of course, but as I said, we have to make sure we're not missing any cause of the shock. We have to correct all the possible causes of shock, or try to manage it before or while using the vasopressors. Because if we use vasopressors and they give you temporary good blood pressure, then someone might think, okay, problem solved, then we are finished. Now our patient is good. No, your patient is not good. Okay, so you have to look for what's causing the shock, okay, and manage it accordingly. Dr. Badr raised hand.
Two things, yes. First, let's keep the question at the end, Dr. Amar, because we have only 6 minutes left. I will comment about the vasopressor after you finish your talk.
Okay. We don't have much left. We'll just speak about 3 cases. Each case will, inshallah, speak in 1 or 2 minutes. Case number 2 is a pregnant lady with in her 32nd week. Was involved in a car crash, and she's complaining about mild abdominal pain. Her blood pressure is 90/60 and heart rate is 137, and she looks stressed. What's our priority in such patient? Okay, is to resuscitate the patient, okay, and monitor the fetus. This is our priority. In pregnancy, we have multiple key points. Maternal survival equals fetal survival. Treat the mother, and inshallah you will treat her baby with her. Okay, in pregnancy you have 2 patients, not just a single patient. And you might, if the patient condition is accepted or might allow the patient to stay in her left lateral position or do a left lateral tilt, okay, just to offload the IVC from the weight of the uterus, so the venous return and the hemodynamics can be better in such patients. One of the major causes of shock in such cases is placental abruption. So put it in your differential list and use the ultrasound and fetal monitoring early as much as possible. Case number 3, an elderly patient fell on the steps and had a head trauma. He's an 80-year-old, fell from a standing. Initially, his GCS was 15, and 4 hours later, he became confused and drowsy. In the CT, when we've done the CT scan, he had a large subdural hematoma. What went wrong in this patient is that the initial assessment was normal, so we said that, okay, he looks okay, there's no need to worry. But the patient was compensating for this bleeding because he has older patients have brain atrophy, so they have more space for bleeding inside the skull, and that's why they may have delayed symptoms. And also they have a high risk for hidden fractures, especially in the hip, ribs, and spine. And even mild trauma can cause major injury because this population segment usually are polymedicated. Some of them are taking anticoagulants, and some of them are taking blood or heart rate control tablets. Last case is a pediatric case. A 5-year-old boy fell from a bicycle with no external injury. Initially, he was vitally stable, but 4 hours later, he became pale and lethargic. The fast ultrasound showed liver laceration with internal bleeding, and the lesson in such cases, on pediatric cases especially, that they compensate well in the initial part or initial phase of trauma, then they suddenly collapse. These types of patients, usually the key to monitor them is their heart rate. If their heart rate is still high, or despite that we've managed the patient in a good way and we've given him good pain relief, and his heart rate is still high, despite that his blood pressure is good, okay, you can stay on top of this patient until you find what's wrong with him. And always suspect internal bleeding in children, even with normal initial exam, and use pediatric scores, and avoid excessive radiation as much as you can. So finally, always follow the ABCD approach. Okay, there are some few exceptions, but always this will save you and save lives. in pregnancy, treat the mother first and avoid putting the mother in supine position, especially in the third trimester. Try to tilt the bed a little bit to the left side. And elderly patient compensate slowly, so watch out for delayed bleeds or anything else like that. And children deteriorate fast. Keep a high threshold for them. Okay, I will send you a common pitfall PDF that has the common pitfalls, inshallah, in it with the solutions for it. Okay, now I am finished. It's time for questions if you like.
First of all, I would like to thank you, Dr. Omar, for your great presentation and illustration about the initial assessment. As all of us knows, and especially as an ER physician, you are the gatekeeper. So usually you are the one who started the initial assessment. So when we get it from the experienced people, it means a lot for us. So, but few point before I would mention my point. Anybody has any question for Dr. Omar or any point from ER consultant? Dr. Arafat, please.
Thank you, Dr. Omar, for your good presentation. I have one question. In the first patient, according to ABCD, if the patient needs intubation for whatever the cause, I should exclude first tension pneumothorax. But if by a clinical examination, if there is tension pneumothorax, what to do first? Needle thoracotomy or ICT, or intubate the patient first?
Okay.
Step by step.
Okay. If there is a need to manage the airway and the patient has tension pneumothorax, you have to relieve the tension pneumothorax and put a chest tube. Okay, then then manage the airway. This is the sequence in such cases. Okay, because if you intubate the patient and we switch the patient from negative pressure inspiration to a positive pressure inspiration, and this can worsen the pneumothorax and put the patient again in a tension pneumothorax. So we have to have a definitive solution for the pneumothorax first, then we can manage the airway next. Okay, in the meantime, you can put like oropharyngeal airway, and someone can give the patient, if the patient is spontaneously breathing or tolerating the airway, this is good. If not, then someone can bag the patient until we manage the tension pneumothorax, then we can proceed with the intubation part.
Thank you, Dr. Omar.
Thank you.
Anybody has other question? ICU, anesthesia, ER, nursing. I'm really proud of the nursing and the other medical services that who are attending the lecture. And as you know, this trauma lecture is not for some, and it's for all of us to improve our trauma care and to improve our patient outcome. I have just few points, and you can correct me regarding the hypotension in trauma. Just a point: all hypotension in trauma is a hypovolemic shock until proven otherwise.
Yes. Good.
So you should not prioritize any other cause for hypotension, and unless you excluded the hypovolemia and bleeding per se. The issue with the bleeding the only thing that we cannot rule out is the retroperitoneal hematoma. Luckily, it's not that common, but sometimes when it happens, it happens. So, as I said, this is the only place that sometimes we are missing regarding the retroperitoneal, the initial assessment, because most of the time we cannot diagnose it unless by CT or by laboratory exploration.
Yes.
The other thing that regarding the vasopressor, it is not favorable at all to start vasopressor for a trauma patient. In a trauma patient, you start vasopressor, I said again, you have to exclude hypovolemia. And as mentioned by Dr. Omar, regarding the answer from Dr. Karim, so we should never start vasopressor unless we gave the whole massive transfusion protocol, and still the patient is hypotensive, and we have the evidence that there is no more, it's not a hypovolemic shock. Vasopressor, actually, it will make everything worse. It will make the brain worse. It will cause more end organ damage. So it is never, honestly, حتى always in any trauma patient, I would put it at the last of my head, and sometimes I don't want to remind myself about it. So again, give blood and massive transfusion protocol. And unless if you have evidence from the ABG or, so for example, you have a hemoglobin of 13 or 14, by an ABG, you have hematocrit and there is no other bleeding, then you might consider the other causes like spinal shock or neurogenic shock. At that time, then we can consider the role of the vasopressor. Regarding the question of Dr. Arafa, if I may add also to Dr. Omar, the patient with the tension pneumothorax and difficult airway, remember that, I know it's a really theoretical question, but how come you diagnose possibility of tension pneumothorax and you pass the airway? So usually if you have a difficult airway, you have to manage it immediately, as we said, because what happened that when we find this scenario, because we are a team, someone is managing the airway and someone else is diagnosing the tension pneumothorax. So we should collaborate together and we do it together. The one who's handling the airway, he can put it, and the one who's handling the breathing, he can just put the needle decompression or insert the chest tube or whatever. The other thing that I think that's it. I took a lot of your time today. Again, I'm really thankful for you, Dr. Omar, for your questions, and I'm thanking for all of you to attend the lectures. Inshallah, we'll see you after 2 weeks with the scheduled lecture, inshallah. Thank you so much for everyone for attending the lecture. Thank you, Dr. Omar, for your excellent presentation.
Thank you, Dr. Badr. Thank you. Thank you,
everyone.
everyone.
Thank you all.
شكرا.
Thank you.